The Mom with Moms podcast is sponsored by Hackensack Meridian Children's Health. Hackensack Meridian Children's Health is comprised of 2 nationally ranked children's hospitals by U.S. News and World Report and are number 1 in New Jersey. Hovnanian Children's Hospital in Neptune and Joseph M. Sanzeri Children's Hospital in Hackensack, as well as pediatric inpatient and outpatient services at JFK University Medical Center in Edison. With access to expert pediatricians and over 200 pediatric specialists across the state, Hackensack Meridian Children's Health prides itself on offering specialized pediatric medical care and surgical expertise. To learn more about Hackensack Meridian Children's Health, visit hackensackmeridianhealth.org/kids. Welcome back, everyone, to the Mom with Moms podcast. We are here in Red Bank, New Jersey, on a beautiful day coming off the heels of Memorial Day weekend, which mostly was very pleasant. Yesterday wasn't too sunny, but overall I'll take it. It was like the first weekend, I think, since like March that hadn't rained. So we were glad to get out and get some sun and enjoy some time with friends and family. But we are back to it, continuing our family healthcare series with Hackensack Meridian Children's Health today. Welcoming Dr. Guillermo Hidalgo. He's an international expert on kidney disease and the Division Chief of Pediatric Nephrology at Hovnanian Children's Hospital at Jersey Shore University Medical Center. His many accolades include serving on the executive board of Saving Young Lives, a collaborative international organization that advocates for acute kidney injury care in low-resource areas of the world. Dr. Hidalgo has been working with the organization in recent years as a physician, lecturer, and trainer of pediatric kidney specialists, treating patients throughout Latin America and in Asia. In addition to training in San Juan, Puerto Rico, Dr. Hidalgo has traveled to Bogota, Colombia, and Singapore to speak about the latest treatments for acute kidney injury and train physicians to treat the condition. The program in Colombia was the first of its kind held in the country. Dr. Hidalgo and the other course presenters welcomed participants from Central and South America to the 2-day Saving Young Lives Project workshop held at Universidad de los Andes in Bogota, Colombia. The program included lectures and a hands-on practical session where catheter insertion was demonstrated and practiced. Welcome. Thank you so much for joining.
Thank you.
I have so many questions about nephrology because it's not, I guess, luckily, is a specialty that either of my children needed. But we were just chatting a little bit, and I have, the Hackensack always sends some notes over of a few questions to keep in mind for moms experience any type of symptoms. Why would a child see a nephrologist? But I have some questions too. So thank you so much for joining. So what are some like we were just talking about UTIs and certain ailments that a child may be experiencing. But what are some of the main reasons that a child would end up in your office?
One of them is that the general pediatrician may do a dipstick in the patient's urine when they come for a regular checkup.
Oh.
And they may find abnormalities on that strip that may warrant for them to repeat those tests through urine analysis and microscopy. And then they find still a signal that will prompt a referral. Those can be micro amounts of red blood cells in their urine, called microscopic hematuria. Or sometimes they can find protein spilling in our kidneys. The kidneys should not be spilling protein. And when they see that, is a typical referral to us.
Okay.
The other causes may include elevated blood pressure when they come in, but you got to make sure that it's not white coat hypertension. Kids, when they come in, they may have elevated blood pressure in the clinic setting. They repeat that one more time or maybe a third time, and if still elevated, then they will probably refer those cases to us to confirm whether or not they have truly elevated blood pressure. We have a device called the ambulatory blood pressure monitor, which kids up to the age of 8 and above can wear for 24 hours, and it'll depict blood pressures every 30 minutes during daytime and every hour at night. And we are interested to see their behavior when they're at home, playing their games, and more importantly, sleeping.
Interesting.
So, hypertension is called the silent killer, at least in adults, because it's rarely detected until it's taken an impact on the heart. And so that would be interesting to try and tease out.
So, elevated red blood cells, protein, high blood pressure, are any of those combined with like any, are children symptomatic other than those or sometimes?
They sometimes do. The other, so that's the glomerular, meaning the kidney filtering units that are abnormally functioning. That will lead to a segment of the referrals. There's another segment that has to do with prenatal findings on mommy's ultrasounds early in gestation, as early as 20 weeks. And some of those patients are going to maternal fetal medicine docs, and they may refer the cases to our Happy Babies program at Jersey Shore.
Uh-huh.
And so they get seen by a group of further specialized maternal fetal docs there with quite a bit of technologies in terms of imaging, and we are able to identify congenital anomalies early, be able to counsel them, direct them to deliver at a proper place, and that's a group. It's called Congenital Anomalies of the Kidney Urinary Tract. It's called CACUT. That's a big segment of the referrals. And other referrals have to do with things that were found by serendipity. As we were talking, kidney disease can be relatively silent, and some pediatricians, for a different reason, may order a kidney ultrasound or abdominal ultrasound for abdominal pain, and they may find stones, they may find cysts in their kidneys. So those are referrals from pediatricians for non-glomerular causes that have to do with anomalies, anatomic anomalies of the kidneys. That may also include reflux, which may preclude the recurrence of UTIs that are febrile, and those we have to pay attention to because they can scar the kidneys and later lead to hypertension or chronic kidney disease.
Oh, okay. So, backtrack a little bit. Nephrology is the practicing only the kidney, right?
Yes.
Okay. And if a child has high blood pressure, what does that even mean? What is high blood pressure?
So nephrology is the segment of medicine that deals with the kidney and the functions of the kidney, separate from what urology means. Urology means drainage, obstructions, anomalies, duplications, down to the bladder out to the, urethra, to the segment that brings the urine out of the bladder. That includes sometimes pelvic organs, testicles, and sometimes. So that's urology and nephrology. Nephrology has to do with about 20 functions of the kidneys, one of which is the generation of urine, but the most important function of the kidney has to do with depriving the body from toxic substances and eliminating those through urine. So every time all of us, utilize, the elimination of urine, and we go to the bathroom, we take that for granted.
Mm-hmm.
But it is a significant area for human survival. The moment you lose your kidneys, you are not going to be the same. You probably need to be on some kind of artificial modality to give you kidney. But kidney is like the liver. There's silent organs that are helping us eliminate all the toxins, but seldom are being addressed.
Right.
So the elevated blood pressure means that there are thresholds and there are apps for diagnosing that, but essentially no kid up to the age of 10 should see blood pressures that are beyond 100/60. And so when you're starting to see elevated blood pressures time after time, you know that there's a problem. Typically, they don't go to cardiology. They sometimes go get an echocardiogram first, but that's somehow just to eliminate cardiac causes of hypertension, which is minimal. The majority of hypertension in kids is related to some degree of malfunctioning of their kidneys. And so that's why they come and see us, because they could have a small kidney, they can have cysts in their kidneys, they can have many other reasons within the kidney that makes them have elevated blood pressures.
Interesting. So kidney stones, is that prevalent in children?
It is quite prevalent, not as much as in the South, not as much, but there's a genetic pool here around these areas of the Northeast that leads to hereditary causes of kidney stone formation. And so again, urology will go in with a basket and pull down their stones, but we in nephrology address the mechanism for kidney stone formation, because that's more of a preventive approach as opposed to just getting them out. Yes, when they are in pain, when they are infected, you have to get them out, no doubt. But it's smarter to work on nutritional modifications for us to stop making kidney stones. That is to the root.
So you're saying that people have a genetic predisposition
Yes.
to having kidney stones based on their, is it?
Not all of them,
Not
but
all of
about
them.
30% of them have
Interesting.
a genetic reason. We have a renal gene panel that we can test on them to see if they have the hereditary type. If not, it's most of the time just nutrition. They have family history of kidney stones. They are taking a lot of salt. And if they are not drinking enough water, that's a perfect combo. Um, when they also have intake of vitamin C, oxalate may play a role. Uric acid in patients who love a lot of red meat. So those are again variables that one can modify easily, so that they stop having kidney stones. But it's quite discomfort, and if one doesn't address the cause,
Mm-hmm.
then that kidney, instead of being a soft, juicy, well-functioning kidney, becomes with multiple kidney stones. And it may become something that's called nephrocalcinosis, in which the kidney, instead of being healthy, becomes somehow petrified.
Mm.
It has a bunch of um, stones being formed in it, and that will lead to kidney dysfunction.
Interesting. I have a note in here about camp season upon us, and that making sure that children are hydrated.
Mm-hmm.
How is that related to kidney function, kidney health, and also a note about overhydration, which is interesting to me because I think we're living right now in a current, society of wellness and self-care and being hydrated. But I ask a lot about, like, to what degree, like, are we overhydrating ourselves with all the Stanley are you seeing children that are coming in and drinking too much water?
No, that's an interesting question for three reasons. One, there is not only camps, but also the temperature of the planet
Mm-hmm.
has gone up. And so there's heat related kidney injuries
Wow.
that is more prevalent in tropical areas where there's now the temperature there is 80 degrees, 100 sometimes in the fields. So when kids go out, it is imperative that moms are, keep reminding them and give them their bottles. It is like a chase
Yeah.
because you tell them they don't do it, then you get mad. So maybe the way to work that out is through giving them some incentives. And that would be to tell them, it's good for your health, but also, hey, there's something reward for you if you are mindful about that and take your water. Number one. Number two is if they have for any other reason to be dehydrated, not only from heat and perspiration, but also because they are not feeling well, then that's a problem. Also, on this note, the use of ibuprofen. Please don't give your kids ibuprofen in the context of being low on their volume. If they are looking dehydrated, they haven't been feeling well, they haven't been drinking well, please use good old plain Tylenol and not use ibuprofen, Aleve, um, naproxen, or ketorolac, or Voltaren, or Toradol. Don't, because that combination of dehydration plus those type of drugs will cause kidney injury.
Oh.
On the note of overhydration, I don't think that we can overhydrate. There are some cases of marathon runners during the summer that have binged a little too much on free water intake, and they have dropped their sodium, called hyponatremia. But that's seldom. It's better to work on the area of having adequate hydration. And lastly is what happens in the reality in New Jersey. A lot of males that are adolescent males are going to the gym. And not only because they want to be pumped, but they are taking the wrong kind of supplements. They are taking protein, they are taking GNC products, and I don't, don't put a label on GNC. Any kind of products,
Mm-hmm.
any kind of stuff that is on the shelf that is not FDA regulated and may have the wrong kind of quality control in manufacturing, that can be deleterious to kidney health. Some of them come with elevated serum creatinine, which is a biomarker for kidney function, and the referral is because they've been not having the best kidney function due to the stuff that they've been taking from the shelves.
Right.
Typically, it's their friends who tell them, hey, that banana shake there, take some of that, you'll be, you won't recognize your muscles in about a week. And it's true, because it has growth hormones, and it has steroids, and it has all kind of anabolic stuff. But that is deleterious to the kidney. So a word of advice to the moms who see their kids taking that kind of stuff, please ask them to go to the right route, and that is nutritious food. If they want protein, have the protein that you know the source of. You want, meat. There are types of meat like white chicken, white turkey, fish, eggs, nuts. There's multiple sources of protein that don't have to be powdered.
Mm-hmm.
And so I always tell them, you need a nutritional consult. Here we have staff to give you advice on that. But please stop taking that stuff.
Yeah, so interesting. Why? So I know that UTIs are, a common occurrence among children. I'd assume perhaps a bit more in the summer. Is that because of being in the pools?
Being in the pool and also being dehydrated.
Okay. All
And
right.
so there are two types of conditions. So 0 to 2 months, bad infections. 2 months to 2 years, still bad infections, but that may have a congenital reason for it. We're only talking about febrile UTIs, fever defined as 100.4 or above of a thermometer. So febrile UTIs are a problem. Afebrile UTI means lower urinary tract, not so much of a problem. But febrile UTIs have an issue with girls, especially between the ages of 3 and 7, mainly around 4 and 5. They have this CEO kind of mentality, and they are absorbed by the activities they are taking. They're not able to detach themselves from that, and they hold their urine. So the majority of them are having urinary tract infections because of incomplete bladder emptying, and that just needs behavioral retraining. And also, another comorbidity there is constipation. So patients who do not have a proper bowel emptying will not have proper bladder emptying, and that conditions bladder bowel dysfunction. Those are very prevalent conditions among males in the same age group. Is related to congenital anomalies. Most of the time, they may have reflux or some other reason for them not to completely empty, but it's different. It's anatomical. In girls, most of the time, thank God, is functional, and one can easily revert that by behavioral therapies, by reminding them and by doing voiding exercise. Older than that, 10 and above, then the majority of them may have anomalies that are related to either hematogenous or lower urinary tract conditions. But it's less likely, and then you start seeing the interaction between that and sexually transmitted diseases that one has to be mindful about between, deciphering which one is which. But UTIs, febrile UTIs, if they are recurrent, and by recurrent we mean 2 or above, then they have to be addressed carefully because they can lead to renal scarring.
We mentioned high blood pressure earlier. Why would a child have high blood pressure? Are there a lot of different reasons, or?
Multiple reasons, but so you, again, group them by age. So pediatric is all about growth and development, and so when they have hypertension early in life, has to be something that occurred in utero, something that made them more likely than others to have high blood pressure, namely sometimes of severe prematurity, some babies that are really small for age, some babies that may have taken the kind of medications within the neonatal ICU that makes them have hypertension. Others may have chronic lung disease. They may have been born with small lungs, with hypoplastic lungs, and medications to relieve that will take care of their blood pressure. Older kids between, say, 0 to 2, they may still have congenital causes of hypertension. Later on, most of them, especially from the age of 8 and above, have essential hypertension. And essential hypertension nowadays is related to diet. They may have a family predisposition for hypertension, but you may delay that just by the proper nutrition. if they exercise, if they take less salt, if they are controlling their BMI. Body mass index is supremely important. It's actually parallel. BMI goes up, blood pressure goes up. They get put on a diet and they don't need medication. They just need to lower their BMI.
Right.
And so those are the most frequent causes of hypertension.
Okay. If a child is experiencing any of these symptoms, high blood pressure, UTIs, kidney stones, their force, obviously, their stop is normally the pediatrician. Is it something that the pediatrician can treat normally, or will they always, be referred to a nephrologist?
Good question. So I think that some pediatricians are somehow advanced or they've been in practice for a number of years, decades. And so they feel comfortable doing the preliminary workup themselves because then they have leverage to say, hey, I need this patient to be seen tomorrow or this week as opposed to 2, 3, 4, 6 weeks out. Other cases, the pediatricians are so engaged that they will send them directly to our emergency room and they'll notify us. And we then stay in contact with the ER so that we are on board in the management of those cases. Example, a patient may have a strep infection. They start peeing out blood, and that may be an inflammation of their kidneys called glomerulonephritis. That needs prompt attention. So it depends on the case, but the majority of pediatricians around here, the group of pediatricians, general pediatricians, is actually excellent. They pick up on stuff real early, and they do the referrals appropriately. And I'm very pleased with the way that the majority of them have direct access to us through something that's called My Chart. It's an icon in Epic in which they can message us, number one. Number two, some of them have, not all of them, but some of them have my cell phone.
Oh.
And so they can directly text me or run by a case, and I can advise them over the phone as to what to do. Some of them may need to come to the emergency room, and that is just because the acuity of it prompts that necessity.
For the various reasons that a child would be seen and treated by you, are many of the their prognosis, is it easily treated with dietary changes? Do they often need medication? Is surgery ever involved?
So thank God the majority of them are relatively easy to tease out and easy to manage. There are some other cases that are more complex. And there are some other cases that the referral got done late. And so they may be in advanced stages of chronic kidney disease. Some of them may come to the hospital for whatever reason, and they develop renal failure. Some of them will recover from that. Some of them do not. There are many, again, the kidney medicine is somehow of a specialty that has to do with the unknown. So it wasn't suspected that somebody may have renal failure, and that is because the body is extremely able to cope. So when we have a deficit, our body is incredibly able to make up for that deficiency and keep on going until it's gone. And when it's gone, then you show up and you say, well, I don't feel well. They do some tests on you and say, hey, you have renal failure.
Wow.
That is less likely in peds because, again, you have pediatricians that are being attentive to those needs. But we have seen a number of them over the last 4 to 5 years here that have shown up to our door with renal failure, and it's very hard for us to convey that message because it's not something that you can deal with. Like, okay, I'll fix this. No, it's a long life trajectory that they will have chronic kidney disease. Yes, they can get a kidney transplant, but that is hemodialysis independent chronic kidney disease. They still have chronic kidney disease. So it's something that once you caught it early, make sure that there's nothing there. And if there's something else, what else can you do to prevent progression?
Right.
The key is and that's why I invest our time. Our practice time is invested in prevention. Is how can you ameliorate the progression of this devastating disease without having to reach dialysis? Our job is to stop patients from having to need renal replacement therapies.
And if they are in a progressive state of, kidney disease, is it something that they have to battle going into their adulthood, or it is? Oh, interesting. Okay.
That's a very difficult transition point. Us in pediatrics, we care for them assiduously. We are always after them and make sure that you do this and make sure you do that, counsel them. Not so much when they transition to adults, because adults, you assume that you're an adult patient. I will tell you what you need, and it is up to you to have it done. If you didn't do your labs, don't come and see me.
Right.
I have no room for you in my clinic. I have 40, 50 patients.
Right.
That's what adults patients practices do. And so when pediatrics and you almost babysit them, you are after them and making sure that this, and that. That is not the case. So we have a transition process, almost like a little passport, that we make sure that they are able to identify their meds, their names, the pills, the pharmacy, when do they need refills, for all of their medication list. That's one step, that they're able to know when their clinic visits are, that they call in for appointments. And so there are steps in which we say, okay, you have checked all these checkpoints, and now you're ready for transition.
Oh, okay.
So we start that at as early as 15, 16 years of age. I recently went to an international meeting, and I was told that in South Africa, if you present at the age of 15 with some degree of chronic kidney disease or some degree of renal failure, you're no longer seen by pediatrics. You're seen by adult medicine.
Interesting.
And so it is quite a bit of an undertaking. That segment of transition medicine is quite tricky because our patients have, the ones that are in chronic kidney disease and advanced chronic kidney disease, they have a number of medications that is not easy to coordinate.
Okay. Where can parents find you to set up an appointment? I know your office is in the Hope Tower.
Yes,
in Neptune?
5th floor, Hope Tower.
Okay.
Jersey Shore, a beautiful building. Our phone number, I can give it out, is...
Yeah, we'll put it in the notes, yeah, so everyone can...
So the easiest way is through the pediatricians. And I've seen some moms that I like moms in New Jersey. They are quite in tune with the needs of their kids. They may or may not agree with the opinion of others, but they know what the kid is needing best.
Okay.
And some of them have reached out even without a referral. The mom just said, no, this kid, I think he needs this. And they come around and we explore that possibility. And indeed, some cases, they needed to be seen sooner. But we are glad that we can accommodate the demand.
That's great. So I'm sure most pediatricians know, to refer you
Yes.
In the Monmouth County vicinity and beyond Ocean County. I know that there's not many pediatric nephrologists in the area at all, which is great that you are right in our backyard. So I hope that a lot of parents are listening and can, even if you're not experiencing, but also just to take note that hopefully in the future, God forbid, you do need to see a specialist, that we have Dr. Hidalgo right here.
It would be nice if they don't need us.
That's right.
But if they need us,
Right.
we're happy to help.
Yeah, and you were mentioning earlier what a great resource that we have in the Hope Tower with all
Yes.
these very incredible specialists, endocrinologists and rheumatologists and nephrologists, and many have already been on the podcast. So some of the moms are familiar, but it is. It is an incredible resource that we have right here in Neptune, New Jersey. So thank you so much for joining and sharing a bit about what you practice and how you can help children in our community to hopefully get better and not have to come back and see you again, right?
That's what I tell some of my family. Like,
I hope I
if
never
they
see you.
really don't need me, I said, one less doctor you need to see.
That's right. All right. Well, thank you. We'll throw
Thank you so much.
all of the information, the notes here, and you can always reach out to Hackensack Meridian Children's Health to learn more. Thanks, everyone.